Welcome, everyone, and thank you for joining us for Thyroid multidisciplinary seminars. We are joined this morning by Dr. Eric Kuo, who's an assistant professor in the Department of Endocrine Surgery at Columbia University Medical Center. Dr. Kuo's research interests include clinical outcomes and health services research, clinical informatics, as well as surgical education. And we have the pleasure of being joined this morning by our discussant, Dr. Jennifer Wang, who is an assistant professor and surgeon scientist in the Department of Head and Neck Surgery at the University of Texas MD Anderson Cancer Center. Her primary clinical and research interests are in advanced thyroid cancers. In addition to her clinical work, Dr. Wang directs a translational laboratory focused on understanding the evolution of thyroid cancers. This is a topic, for those of you who were with us last week, that we covered in part. And the paper that's being presented this morning is a primary study conducted by Dr. Kuo, who was the lead author there. So I welcome everyone to this morning. We always welcome your questions that we'll try to get to. We are joined by Dr. Shaha, as always, who's on the another part of the world in India at the moment. But I do want to make note of our Voices of Wisdom podcast. And we are releasing these every month. I believe it's the third Thursday, or Voices of Wisdom. And hope that all of you will take the opportunity to listen to those. They really have been spectacular and very much worth the listen. So with that, I'm going to turn over the session to Dr. Kuo. And in advance, thank you so much for your time and effort to put this together here.
Well, thank you all for having me. And I do want to thank the Thyroid Head and Neck Cancer Foundation for the opportunity to present our work here today. I did listen with a lot of interest to what Dr. Pashkin and Dr. Alexander had to say on this topic last week. And so what I can hopefully elaborate today and continue to contribute to what I think are, really important discussions about how we really optimize the way we evaluate thyroid nodules with respect to molecular testing in this country. So I have no disclosures. Here's an outline of my goals today. So first, I want to set the stage for our study by briefly describing the history of molecular testing in thyroid nodule evaluation, as well as highlighting institution-level effects that we've noticed of molecular testing adoption. This is going to set the stage for the interpretation of our national study, where we looked at trends in molecular testing utilization, as well as thyroidectomy rates nationally. And lastly, evaluated evidence to see whether there might be a causal relationship linking the two. So as was reviewed last week, molecular testing in the evaluation of thyroid nodules has evolved significantly over the last decade. That story begins in the 2000s with kind of more targeted mutational analyses. It's really difficult to discuss this without mentioning the work of the Nikifórovs. This was a study they published in 2009, looking at 6 genetic alterations in thyroid nodules, including BRAF, N, H, and KRAS, RET PTC, and PAX8 PPAR gamma rearrangements for patients with benign, malignant, and indeterminate cytology. And this is where we can begin to see the origins of the primary way we use molecular testing today. Specifically, the large majority of patients with indeterminate cytology and no identifiable mutations did end up having benign disease confirmed on surgical pathology. And although this small 6-gene panel was not able to rule out cancer sufficiently, this work did open the door to the idea that if you could cast a wide enough genetic net, the negative predictive value would be sufficiently high to rule out malignancy in these indeterminate nodules. Building off of this, the first generation of molecular tests were designed to have this high sensitivity to rule out malignancy. either by expanding the number of mutations that were queried or through machine learning algorithms of RNA expression. And so Afirma GEC, the gene expression classifier, and Thyroseq version 2 were designed as rule-out tests for malignancy in category 3 and 4 nodules. GEC used a machine learning algorithm to classify RNA expression, while Thyroseq version 2 expanded from that 6 genes originally to a 56 gene panel. During my time as a research resident at UCLA, we conducted a randomized trial comparing these two commercial platforms. We randomized 157 patients with category 3 and 4 nodules to receive one of these two tests. Real world validation studies of these are challenging in the sense that false negatives are difficult to prove because a lot of these patients undergo sonographic surveillance rather than surgery. But if you assume nodules with negative molecular testing and that don't grow on future ultrasonic graphic surveillance are benign, the ability of and performance of Afirma GEC and Thyroseq version 2 were both excellent and equivalent at ruling out malignancy. However, in this study, we did find that Thyroseq version 2 did have a superior specificity. The second generation molecular tests were released in kind of the mid-late 2010s and iterated to improve on the limitations of this first generation of molecular testing. Their goal was to improve specificity while maintaining the same high sensitivity, as well as improving the performance in Hürthle cell neoplasms. Afirma GSC expanded their genomic analysis, as well as incorporated the expression atlas to identify specific driver mutations. Thyroseq added a genomic classifier as well. And in a lot of ways, each company kind of added on components of their competitors' test to augment their own test in this new generation. Performance again between Thyroseq version 3 and Afirma GSC were continued to be comparable with a high sensitivity for ruling out malignancy, while the specificity of Afirma GSC did improve to match that of Thyroseq version 3 from what we observed at UCLA. So given this data, I think the basic question to ask is, do molecular tests work in the evaluation of indeterminate thyroid nodules? And I think it really depends on what the meaning of work is. If by work you mean the test performance, its sensitivity, specificity, positive, negative predictive value, I don't think there's any denying that it does work. However, I do think there is a more pragmatic and arguably more appropriate definition of work when it comes to molecular testing and how we use it in clinical practice. And that is whether molecular testing is accomplishing its intended goal. And is there a measurable decrease in the rate of unnecessary thyroid surgery? And prior to our study, I don't think an attempt to answer this question have been made on a national level. So that brings us to the origin story of our study. And to really set the stage, I'd like to consider this statement. That is, the increasing adoption of molecular testing has led to decreased thyroidectomies being performed per fine needle aspiration nationally. And in considering this statement, I want you to do a little sniff test of it. Does it seem right? What is your general gestalt as to whether it's true or not? And on first glance, I think it absolutely makes sense. Given all the data on molecular test performance that I just presented, it's really hard to imagine that thyroidectomy rates are not decreasing. However, as an endocrine surgeon that does have a portion of their practice dedicated to thyroid nodule evaluation and biopsies, I do have to say that, the more I evaluate thyroid nodules, the more I started to doubt, what sounded like this very obvious conclusion. And so personally, what I started to experience is that, every Friday is my biopsy day, which means that the following Wednesday afternoon, I get a batch of results back. And not infrequently, I would notice that the number of category 3s far outweighed the number of category 2s. And out of the 6 biopsies maybe I did that day, 5 would come back category 3. And really, this prompted us to take a closer look at our own institutional call rates for this. So we noticed that after the introduction of molecular testing, there was a steady increase of Bethesda 3 results from 7.6% down in 2017 all the way to 18.2% in 2021. And not only that, we also had a decrease in Bethesda 2 call rates during the same time period, such that the sum of category 2 and category 3 results remains constant, which really raised the question, is there a contamination or mixing of these category 3 results with category 2 results? And I do think the answer is probably yes. Although our thyroidectomy rate for Bethesda 3 patients did decrease by almost half, that doesn't mean as much if they had their test 5 years ago, it was actually a benign biopsy and really wouldn't have needed surgery in the first place. Over the study period, we also found that the number of suspicious or positive molecular tests, depending on whether we used Afirma or ThyroSeq, decreased with time. And the yield of malignancy in patients where we did operate did drop as well, further supporting this concept of diluting our Bethesda 3 category with Bethesda 2s. And this phenomenon, looking at the literature, is by no means limited to our institution. Cedars-Sinai looked at their experience pre and post molecular testing and found that the category 3 results increased from 10.7 to 13.4%, while category 2 results decreased from 74.6 to 68.8%. And at Pittsburgh, the results were even more dramatic. So their category 3s increased from 21.3% to 55.8%, while the horizontal bars here, which show the sum of category 2 and 3, show that number to be pretty constant. So suggesting that there's this migration from category 2 to category 3. So given this, I want you to consider a little thought experiment here. Let's consider a pre-molecular testing era where the rate of indeterminate biopsies is about 15%, and maybe not all of these undergo surgery. So we have a little lower of a thyroidectomy rate of 12.5%. I know these numbers are debatable, but just humor me for now. I do think they're in the ballpark. Now consider a post-molecular testing era where the indeterminate call rate is 50%, kind of what they reported at Pittsburgh, and assuming that 25% of these come back positive, these molecular tests come back positive and undergo surgery, the thyroidectomy rate also becomes 12.5%. So I really think we have to ask ourselves, what have we really gained here? If per FNA, we're performing the same number of thyroidectomies as before, only we're using a lot more resources and costs of molecular testing to get there. And I do think this has, a lot of implications for the cost of thyroid nodule evaluation as a whole. So, if you consider that maybe up to 50% of adults are going to have a thyroid nodule at some point, and if 50% of these have indeterminate results that undergo molecular testing, I really think we have to ask ourselves whether this is a sustainable model of thyroid nodule evaluation. But what about all the studies on cost effectiveness of molecular testing? Study after study shows that molecular testing does appear to be cost effective. But what's important to remember here is that molecular testing doesn't happen in a bubble, but rather within this larger context of thyroid nodule evaluation, considering these other cytologic categories as well. When you look at cost effectiveness analyses that conclude that reflex molecular testing is cost effective, they are comparing reflex molecular testing to the alternative of diagnostic lobectomy when you look at their Markov models. And in actuality, this may not be the only management option for these patients. So in contrast to reflexive testing, selective testing after repeating the FNA could potentially be cost saving, as a significant portion of these patients who undergo repeat FNA do end up having a benign result. This is a study also from UCLA of a cost-effective analysis comparing selective molecular testing strategy with a reflexive molecular testing strategy. And they found that selective molecular testing was more definitively more cost-effective than a reflexive one. Pictured here is their tornado diagram, which depicts how sensitive their Markov model is to varying assumptions between kind of extremes of their variables. And for almost all the variables in this study, you can see that they don't cross this dotted line on the right, which means that selective molecular testing is more cost effective. And really the only variable where the reflexive strategy was more cost effective was when the cost of molecular testing dropped below $1,000, which is significantly less than the current cost of these common molecular testing platforms. So now I think we've set the stage for the hypothesis of our study, which is if we think that looking at thyroidectomy rates of indeterminate nodules may not be reliable because that category itself seems to be kind of a moving target that is being increasingly contaminated with benign nodules. We can instead look at thyroidectomy rates in all comers who underwent FNA. And if molecular testing is accomplishing its goal, number one, I think the fraction of patients biopsied who undergo a thyroidectomy really should be decreasing over time. And then number two, if molecular testing is being adopted at different rates by different groups, we can hypothesize that high adopting groups should have a lower thyroidectomy rate than low adopting groups. So to answer these questions, we performed a retrospective analysis of the MarketScan research database, which contains largely commercially insured patients throughout the United States. Patients who underwent thyroid fine needle aspiration from 2011 to 2021 were selected, and molecular tests that were included these commercially available DNA and RNA platforms, as well as the more focused kind of targeted mutational analyses. And we determined whether these patients eventually received thyroidectomy or not. So we identified a total of approximately 460,000 patients. And we first looked at the demographic variables that seemed to impact molecular testing adoption. We found that the median age of patients who received molecular testing was younger than patients who didn't receive molecular testing. We also observed that molecular testing was less frequently performed in Black patients compared to white or Asian patients. Molecular testing was also less frequently performed in patients who lived in a non-metropolitan statistical area, or MSA, which is a measure of population density. In other words, patients living in rural areas were less likely to receive molecular testing as well. Next, we graphed molecular testing rates and thyroidectomy rates over time. Over the study period, the rate of molecular testing increased from 0 to 10%, while the thyroidectomy rate decreased from 17.5 to 12.5%. So on first glance, it does look like that thyroidectomy rates are decreasing as molecular testing adoption increases, although we're going to test the second part of that hypothesis in other ways later. And the other thing I want you to notice is that between 2015 and 2016 is really when molecular testing started to take off. And going back to our timeline, coincides with the introduction of these first generation molecular tests, as well as the American Thyroid Association guidelines that really commented on their appropriate use. So next, we analyze utilization of molecular testing by technique or platform, as each molecular test does have its distinct CPT code. And what you can see here is that around 2016 is when these commercially available platforms, including Afirma, ThyroSeq, Thyrogenex, and ThyroidMere, started to dominate, while targeted mutational analysis started to fall off. I do believe there are some coding artifacts that limit the interpretation of these curves. Not all of these tests had their own, personal codes immediately, and probably had to use some of these other codes. So there may be some overlap and mixing. But I do think that the takeaway here is that molecular testing in the latter half of our study is really dominated by these commercial molecular testing platforms, with Afirma being the most commonly used, followed by ThyroSeq, and then Thyrogenex and ThyroidMere. Next, we looked at adoption of molecular tests by region, where you can see that there's a pretty even adoption of Afirma and Thigenext and Thyromere nationally. Thyroseq looks like it took off a bit faster in the Northeast compared to the other regions of the US. And I think this is likely due to its geographic location, Pittsburgh. The increased frequency of targeting mutational analysis also in the Northeast. I wonder if it has to do with some crossover between these Thyroseq codes as well, but unclear. Next, we wanted to see if there was a difference in thyroidectomy rates based on the molecular testing platform that was used. For Thyroseq and Afirma, you can see that approximately 20 to 30% of patients who undergo testing, end up having thyroidectomy, while this rate seems to be just a little bit, maybe a little bit lower with Thigenext and Thyromere. Okay, so now getting to the meat of our hypothesis, we really started off with just a simple scatter plot. Molecular testing rates on the x-axis, thyroidectomy rates on the y-axis. And again, our hypothesis was that as molecular testing rates increase, we would see that thyroidectomy rates would decrease. In part of A of this figure, each dot represents these rates over a single year. And there we did observe a near perfect correlation between thyroidectomy rates and molecular testing rates. In part B, rather than each dot representing a year, each dot represents a state. And although less robust, you can see that there is a statistically significant correlation between increasing molecular testing rates with decreasing thyroidectomy rates, suggesting that higher adopting states do have lower thyroidectomy rates than lower adopting states. However, I do think we have to keep in mind that this is a correlation, and the next logical question becomes whether this is causative. One of the ways we approached answering this question was in interrupted time series analysis. So interrupted time series analyzes the effect of an intervention on an outcome over a defined period of time. And basically what we're analyzing here are the characteristics of these lines, pre-intervention and post, comparing them to the characteristics of the line post-intervention, which is after this vertical line here. So on the first diagram on this far left, you can see that the slope of the line doesn't change, but the y-intercept does, which means that the intervention resulted in an immediate but not a sustained effect on the outcome. In contrast, in this middle diagram, the y-intercept is the same, but the post-intervention trend slope does increase, which means that although the change was not immediate, there was a sustained effect post-intervention. And then lastly, on the figure on the far right, because both the y-intercept and slope increase, you can interpret that there is both an immediate and a sustained increase in outcomes post-intervention. So applying this to our study, we plotted molecular testing rates and thyroidectomy rates over time and evaluated whether there were any, number one, immediate changes in molecular testing or thyroidectomy rates, which is signified by the changes in this y-intercept, beta 2, as well as sustained changes as evidenced by this slope of that post-intervention line, beta 3. With respect to molecular testing, we found that there was an immediate and sustained increase in the rate of molecular testing adoption, with significant changes in both the y-intercept, beta 2, as well as the slope, beta 3, post-2015. However, with thyroidectomy, we did not observe this significant change in the y-intercepts or the slope. And this suggests that while molecular testing became increasingly utilized after 2015, thyroidectomy simply just continued on its pre-2015 trend rather than really accelerating. So just to kind of summarize where we've come so far, with respect to hypothesis number one, it does look like, that thyroidectomy rates may be correlated with molecular testing rates, although the magnitude of the changes in thyroidectomy rates may not be necessarily paralleling that of molecular testing. However, with hypothesis two, our next goal was to evaluate whether high adopting places have a lower thyroidectomy rate than lower adopting places. When I initially conceived of this study, I was hoping that the database had institution codes so that we could analyze this on an institutional level. But because those were not available, the most granular data we had were on the state level. So what we did is a difference in difference analysis by state. So similar to interrupted time series, difference in difference analyzes outcomes pre-intervention and post-intervention. And so in this example, you have a red group being compared to a green group, and the intervention that is occurring at the time of this vertical line here. And so if the intervention doesn't have any effect, it's going to continue on this kind of dotted line. And the difference in difference analysis is going to assume that any difference in the outcome is going to be attributable to the effect of this intervention. And it's the difference in this difference that is the effect of the intervention. And so in terms of our study, if molecular testing is, quote unquote, working and is decreasing thyroidectomy rates, we would hypothesize that there would be a greater decrease in thyroidectomy rates when we look at high adopting states compared to that of low adopting states, and that the difference in these two rates can be attributed to the intervention, which is in our case, the introduction of these molecular testing platforms and the ATA guidelines. So we defined high adopting states as those where molecular testing adoption increased by at least 10%. There were about 16,000 patients in this group where the collective molecular testing adoption rate increased from 2.4% pre-2015 to 15.3% post-2015. We then identified 5,700 patients in low adopting states where increases in molecular testing adoption decreased by less than 5%. And in these states, the pre-2015 adoption rate was 1.6% collectively, followed by a 5.6% adoption rate post-2015. And again, if molecular testing is working, we might hypothesize that rates are going to drop more in these high adopting states. So this is the results of our difference in difference analysis. And we actually observed the opposite of that. So in high adopting states, the thyroidectomy rate dropped from 15.9% to 13.4% when we compare 2015 to 2021, which amounts to a difference of minus 2.5%. However, in the low adopting states, the thyroidectomy rate actually dropped more from 18.5% to 13.2%, amounting to a difference of negative 5.3%. And the difference in differences here is minus 3.2%. So while the magnitude of the decrease in the low adoption states is actually higher, I think what's also important to note here is that the absolute thyroidectomy rates in 2021, in the year, most recent year of our study, was very similar between low and high adopting states. So I think one way of interpreting these results is that molecular testing maybe just kind of evened out these thyroidectomy rates, and that low adopting states really just had further to fall. So to summarize our results, I do think that molecular testing is increasingly adopted in the United States. There does seem to be an inflection point in 2015 that corresponds to the introduction of these commercial molecular testing platforms, and that the ATA guidelines commenting on their use also contributed this as well. Molecular testing, I do believe, is less utilized in the elderly, Black patients, and patients who live in rural areas. Along with this, we observed that thyroidectomy rates per FNA are decreasing as well. The states with higher molecular testing rates tended to have lower thyroidectomy rates. However, the decrease here did not parallel the immediate and sustained changes that we observed in the molecular testing rates on our interrupted time series analysis. And then lastly, with our difference in difference analysis, the decrease in thyroidectomies was not as drastic in the high adopting compared to the low adopting states. So our study does admittedly have a significant number of limitations. Market scan is a younger, more commercially insured population, which may not be entirely representative of the US population. I do think there's some crossover between the different CPT codes for the molecular tests which limits our breakdown of analysis by test type. But I do believe, though, that the sum of these does, pretty accurately capture molecular testing. The FNA results are not available in MarketScan, but again, I think given the possible drift in cytologic diagnoses that's happening with time, I think it's potentially an advantage of our study that we're normalizing our thyroidectomy rates by the number of total FNAs, which I think may actually be more accurate. And then lastly, my personal biggest regret with this study is that we had to kind of use state level data as opposed to institution level data, which I think is much more likely, and maybe we would have identified some signal there, as opposed to what we found comparing the states. So at the end of the day, I do, despite everything I've said today, I do use molecular testing in my personal practice. And our institution does employ a reflexive molecular testing strategy, although I think there is good evidence out there to really consider alternatives to this. I do believe that there's a national, maybe a contamination of these category 3s with category 2s that's happening, and that institutions really should be looking at their own call rates for this. And I also believe that, when you take this to the extreme, where maybe 50% of thyroid FNAs are being sent for molecular testing, I wonder whether that is a sustainable model for how we evaluate thyroid nodules. And lastly, I hope, if nothing else, this study has demonstrated that thyroid nodule evaluation is kind of an invasive target that has a lot of moving parts, and that's a really complex issue that we have to be really thoughtful about moving forward. And with that, I'll give it over to Dr. Wang.
Thank you, Eric. That was great. Thank you so much for sharing your really thoughtful study with us. And for some reason, my Zoom is not letting me share, but I can talk. I think that, the initial slides I had were summarizing the findings of your study, which I thought you summarized very nicely, so I don't need to go over them. But I did have some kind of specific points that I wanted to discuss with the group here, which I wanted to make this discussion session more interactive. I think the first part that you pointed out is the advantage of the MarketScan database in allowing us to look at this national cohort at scale, as opposed to individual level, kind of institutional level data. And I think that's actually really interesting because it gives you a bird's eye view perspective of what's going on, versus typically we think about these in our institutional level situation and applying specifically to our practices. But I think it's interesting to see just nationally where the trends are heading. One of the questions I had was, in the MarketScan data, are you able to determine who's ordering the test? Because I think one of the most interesting pieces of information we can gather from these databases is who is the target population for these molecular testing companies, and and how are they using this test?
Right. I don't think MarketScan does have that data, but like you said, thyroid nodule evaluation is something, and I think this is something that's unique about it. It's so scattered across multiple specialties, right? You have endocrinologists, radiologists, surgeons, all having overlap doing the same thing. And so I think that would be interesting data to see kind of what kinds of physicians are ordering this.
And what's been the experience at your institution? Is it typically surgeons that order these, endocrinologists? Are the well, I guess yours is kind of reflex. So is that kind of ultimately determined by the radiologist at your institution?
Yeah, so with our institution, we initially started out, the advantage of Thyroidectomy and Thyromere was that you didn't need to take an additional pass to do that, to test for that platform. And so initially, if our pathology lab or cytopathology lab didn't have that extra pass, they would reflex indeterminate results to Thyroidectomy and Thyromere, which is why that initially took off at Columbia, institution-wide first. But then as we got more, familiar with Afirma and ThyroSeq, we started using those more routinely. And so at this point, our pathology labs will reflexively order Afirma, and it's the pathologist that's actually like the ordering physician for the molecular testing.
Okay. And then I was interested to know from Dr. Erkin, maybe Dr. Shaha's experience, who's ordering the tests at your institutions?
Yeah, so in my institution, it is more reflexively done by the cytopathologist, and the decision to, unless there's a caveat that this patient's going to require surgery regardless of the outcome of the cytopathology, which one are, and the decision becomes one of whether to pursue upfront total versus hemi. So it is, I must say, more reflexive approach to the decision. Ashok, would you be able to answer that question?
Yeah, yeah, sure, absolutely. At Memorial, whenever we do the biopsy, the pathologist or cytopathologist looks at it right away. And if it looks like it is not benign and not malignant, they will collect one more specimen and keep it in the refrigerator for future use. And when the final report comes, they will say, this is Bethesda 3 or 4, and we do have a sample for molecular testing. If you want to send it, please order it. So who orders? We order as surgeons. Majority of the thyroid nodules in Sloan Kettering are evaluated by surgeons as opposed to endocrinologists. They are primarily interested or primarily focused post-operatively when the final pathology report is thyroid cancer. But we evaluate the thyroid nodules more commonly, and we suggest the needle biopsy and the molecular testing of choice, which has been in our institution for the last 7 or 8 years, is ThyroSeq.
Yeah. And that piece is always interesting to me because my general feeling is that there is a difference in the test preference depending on who's ordering it. And surgeons may have a different preference of a specific test compared to, other providers. Okay.
I just want to add one more thing, Mark, if I may. Even though the molecular testing may come back as positive, the RAS, etc., we still use our clinical judgment, the ultrasound findings, to make a decision as to whether this patient should go to the surgery or not.
Yeah.
Unless it is BRAF, we don't use that as a decision maker.
Yeah, exactly. And I think Eric, Dr. Kroll highlighted that very nicely. And that's something that I had thought about as well, is that I think as surgeons, a lot of times if we want to define usefulness for molecular testing, ultimately for us, it means that it alters our surgical decision making, right? And a lot of times, especially in high volume centers, our ultrasounds are quite informative. The surgeon also sometimes just has specific kind of spider sense of what's going on that informs their decision making, and ultimately the patient preference as well. So the point I wanted to kind of discuss is that usefulness actually varies depending on which provider we're talking about. So for surgeons, there are all those complexity of factors and experience that ultimately will determine how useful or not useful molecular testing is. And then, but if you look at the endocrinologist, for example, or pathologist or radiologist, who, or even at the patient level, if they're able to get this themselves, the usefulness to them is whether they should be seen by a surgeon, right? So those are very different questions that I think we have to keep in mind when we interpret the trends of molecular testing. Can I go to the previous slide? Slide 4. Yeah, so Dr. Cole highlighted this very nicely, but one of the things that I did want to point out was this idea of targeted mutation testing. Was there a way that we could determine from the market scan data to see if the targeted mutation testing was done on this thyroidectomy specimen and not the FNA itself?
Yeah, we couldn't figure out a way to really to work around that. Basically what our algorithm was is that we looked at the data of the FNA, and then we queried the 3 months after that to see if there were any molecular testing codes that were done within that time. So I think because of that algorithm, there is some contamination of that with targeted mutation analysis being done on surgical specimens there, which is why I think in the next slide you can see, the effects of that.
Right. Next slide, please. So that was one of the observations that I made was that I think when we're looking at testing on the specimen after the thyroid has come out, generally speaking, we're asking a different question of likely related to the prognosis of the lesion as opposed to diagnostics. And that's something I think as a field too, we're at a stage where those two purposes are getting mixed. And I know that both Thyroseq and Afirma and other companies are looking to also develop a prognostic test. And that's something I think will also complicate the picture of how we interpret this. Because, for example, with the addition of TERT promoter mutation information into the molecular test, we're definitely slowly merging into this prognostic test territory that I think will further complicate the adoption trends that we're seeing. Next slide. So this was highlighted and summarized very nicely by Dr. Kuo, and I won't spend too much time going through this, but basically what I wanted to highlight was that the tests have been evolving. And what's interesting is that, despite sort of changes in the platforms, really Afirma, if you look at numbers, is dominating the market, and Thyroseq, other than in the Northeast, the numbers in comparison are substantially less. And one of the things that is very different that was highlighted by the randomized control trial is just the technology behind these molecular tests that I think we need to think more carefully as a group who are going to be adopting this testing. Next slide. So, just a brief overview of this. DNA is looking for, when we do a DNA test, we are looking for specific mutations, insertions, deletions that are found specifically in thyroid cancer. We're looking for driver mutations where BRAF V center E is a driver in about 60%, and the RAS mutations accounts for another 13%. In the other categories that are not BRAF or RAS driven, fusions accounts for another roughly 5 to 10% of patients, particularly those that are younger. And the other remaining group of patients, the drivers are not as consistently seen across patients. And that group, we're still trying to define the specific mutations that drive that group of patients. So, with the DNA level information, you can accurately identify, I would say, primarily the BRAF driven patients. And the fusion driven patients are actually better sometimes identified using RNA sequencing technologies. And then, the gene expression assays that we have are looking at the RNA level after transcription, and ultimately, at the protein level, there's certain implications as well of the functional impacts of these alterations that none of these assays are looking at. Next slide. This is, again, just an overview. Afirma, even though now they're reporting out variants, for example, BRAF mutations, it is still a RNA-based test. And their platform is now related to covering the entire transcriptome over 20,000 genes. And the number of genes that are actually useful varies across different patients. And basically what the company markets is that at least 10,000 genes will be reported. This is something where in order to detect the genetic changes at the DNA level, they're really looking at variants that are expressed, meaning that they are using the gene expression information to infer what's happening at the DNA level, which I think is important to keep in mind. This is in contrast to a Thyroid-seq, for example, which is actually sequencing the DNA to call out the mutations. And then the Digenex Thyromer also has that technology as well, where they're doing specific targeted sequencing for the mutations. And then targeted mutation analysis actually can vary depending on what the institution does. Most of the time for the driver mutation, such as BRAF, that's done using DNA level analysis. Some institutions do fusion analysis with RNA data, but typically, when we have FFPE material, which is kind of what is available clinically. The RNA sequencing technologies are not as robust. And most of the time, we rely on DNA level sequencing for targeted mutation analysis. Next. So again, I won't go over this, but this is, I thought was a very nice randomized control trial. This type of data is really lacking, and I'm glad to see that there's more efforts in generating robust kind of head-to-head comparisons. So look at the different assays we have available, which hopefully in the future will help inform our decision-making and selection of molecular testing assays. Next slide. I thought this was a very kind of thoughtful study, which relates to the point I was trying to make earlier about not just looking at sort of sensitivity, specificity, negative predictive value, positive predictive value, but thinking critically about what this test is actually doing. And one of the pieces of this RNA only type of assay that's always bothered me was that when we're calling out variants at the DNA level, there's certain limitations there, right? Meaning that really you are detecting variants at the DNA level that are highly prevalent. So BRAF mutation works because typically BRAF mutations are clonal. So the allele frequency there are usually high enough that you can detect it. But the piece that's technical is also just how pure is the material you're going to be getting, right? So in this study, they found that for FNA samples, the detection rates are lower for pathologic variants using RNA-seq data. And one way to get around this would be to use a cell block, for example, but there is that technical difference of how pure the tumor is. And also, other mutations that we may be interested in detecting that are not necessarily clonal or subclonal in certain populations, patients, for example, TP53 mutations is a classic one where the mutation, even though it's present, may not correlate with the amount of mRNA or protein that it produces. So something that I think it's very important that I'd like to see sort of more transparency when we talk about these type of tests in terms of not only kind of overall sensitivity specificity, but how good is a test at detecting the variants it's reporting out. Next slide. And another important issue in interpretation of RNA-seq data that I want to highlight, which is this is the platform that the Afirma uses, is that really every time you do an RNA-seq experiment, there is technical effects that needs to be accounted for that varies between each individual experiment. So every time in principle you send a test sample to Afirma, they're doing another experiment. So there is going to be variations in the signal that you get due to just being in different batches that we have to be able to account for to determine, how accurate each result is. So I think that with the update of RNA-seq technology and with the different sequencing platforms, it's a bit unclear to me what this actually technical variation is, and whether that actually impacts those estimation of malignancy rates that we're getting in our reports. Next slides. So again, going back to this initial discussion point, ultimately, as a surgeon, the question that we're asking is, does molecular testing change surgical decision making? And I would say that, in my personal practice, where it is useful would be if I have a high suspicion that a lesion is benign and I'm not very interested in doing surgery in particular individuals, that's where, for my practice in the setting I'm in, that's where it's the most useful. But again, I think that really varies, and we need to think more about kind of who this is useful to. And then, as a future direction, if we all agree that molecular testing will be useful to our community in one form or another, what are the barriers to adoption, and how can we make the test not only more accessible but more useful for our patients? So one of the things that was highlighted is cost, right? So $1,000 as the sort of limit of cost effectiveness makes a lot of sense to me. I think that with the high throughput nature of our sequencing technologies, and $1,000 is very reasonable for this to be done. And I think that we have to think critically about why something nowadays is not $1,000 or less for this type of testing. And insurance coverage is obviously very difficult to navigate. And I think that with the changes in the FDA coming up about how biomarker testing is going to be regulated, hopefully there'll be more critical look at what actually should be covered or by insurance and what should be provided clinically. And lastly, the turnaround time piece is very interesting, because I think that this is where there is definitely room for improvement as well. But this is something that is tricky to do if we're sending these tests out and and then needing the interpretation to come back through a third party. So the piece that kind of goes into this is not only doing the assay themselves, which nowadays, that's really quick. It could be done within a day. The issue is more the interpretation of this, and to just making sure that the signal is teased out from the noise, and having a robust bioinformatic pipeline and in-house and a molecular pathologist that can evaluate this information. I think that if we can get these tests back in a more timely fashion, that would certainly increase the adoption of these molecular testing. And also, I think, for me, one of the key barriers that I see is just our ability as clinicians to really interpret the genomic test truly in terms of what combining our knowledge of thyroid cancer, which in many cases is quite extensive, with what the test is showing. And I think that, sometimes there's a disconnect there, because we see this number that this test spits out to us, and that doesn't match with what our experience kind of tells us. So I think that there has to be a better way for us to reconcile those pieces of information, and for us to learn more specifically about exactly what the test is doing. That the test needs to be less opaque, so we can interpret the findings for a patient. And lastly, I think the question that's evolving in the field is, will a prognostic molecular test help? And and will it just complicate the picture? And if we were to go and develop a prognostic molecular test, what should be the best method that we use to make that happen? So thank you.
That's terrific. Thank you very much, Eric and Jen, both outstanding presentations. I have a few questions here. Eric, could you parse out what the net adoption is if you factor in the classification migration from Bethesda 2 to the indeterminate, just maybe if you can just and maybe comment on why this migration has taken place here.
Yeah, so I think we were able to kind of see effects of that migration on our, in an institutional level when we looked at our own data. And I think because of that, it's actually misleading when you look at studies of only indeterminate nodules. And really the advantage to this national study is that rather than that denominator being all comers of indeterminate nodules, it's actually the entire denominator of thyroid nodules in general that are being FNA'd. And so by doing that, you are kind of skipping a step or of kind of avoiding that whole issue of migration altogether. So that is, I think, an advantage of our study design, actually.
But you can't separate that out if the real group is how many patients who have indeterminate cytologic features. That's your N, and if that N is growing, then your molecular testing rate is going to grow as a result of that.
Right. So I guess my assumption is that, this increase in indeterminate cytology is not necessarily a true increase, but rather this migration. But that's exactly right. Like I think if truly we are seeing more indeterminate nodules than we were in the past, that applies. But I'm not sure if, yeah, maybe that's true. I don't know.
And I guess the question is if do you have a theory or Jen as to why there is this Bethesda 2 to 3 migration? Is it because molecular testing is available and
That's what, we showed this data to our pathologists and they were shocked. They're like, I think they're subconsciously doing this. They have these molecular tests that are there as a backup. They have this conference where multiple pathologists review these results. But I think naturally, because there's this alternative, there's this almost subconscious decision making of, if we're not really completely sure that this is indeterminate or benign, maybe we'll just let the molecular testing decide. And I think that, that may be the psychological reason why this is all happening.
Yeah. So to that point, what's interesting is that we don't do this on every patient, but in the patients that get molecular testing, our pathologists will actually read out their final pathology based on the molecular testing results. So
okay.
I think you're onto something there. So I think they're waiting for the molecular result to actually make their determination in some cases.
Great. Eric, you identified that there is a demographic cohort of Blacks, elderly, and rural patients in whom molecular testing is not as prevalent. Do you perceive this to be something to that cohort uniquely leading to a lesser reflex or selective approach to using molecular testing? And or is this an adoption of the ATA guidelines issue? And so I guess my question is, does that group is that group at risk of other failures of ATA adoption that would correlate with them being vulnerable to less likely to have molecular testing? That's just a terrible question, but so I apologize.
No,
But if you get my drift here.
yeah, no, I think it is, to me, what it says is that it just reflects an overall kind of decreased access to medical care, generally speaking, probably for those populations. If you're rural, if you're a minority, elderly patients, maybe a slightly different reason. Maybe, we're less likely to, molecular testing may less likely change our decision making in those patients. But, I think it does reflect a decreased access to modern medical technologies.
Okay. And do you know if the ATA other aspects of ATA adoption, guideline adoption, correlates specifically with that demographic?
Yeah, no, I think that there are other studies that have been published by other groups looking at ATA guideline concordance, and that it is lower in these populations that have decreased access to care.
Okay, awesome. Jen, any final comments here?
No, I think I appreciate all the effort in generating robust evidence around this topic. I think that's much needed for us to go forward as a field, especially as we generate more assays, which touts more clinical utility. I think it's really important, and I congratulate Dr. Kuhl for putting together this really thoughtful study.
Terrific. We are unfortunately at the end of the hour, and I apologize. There was a question from the audience that we did not get to. I apologize for that, but definitely want to thank all who tuned in this morning, and specifically want to thank Eric and Jen for a really thoughtful discussion. Much appreciated. I hope you'll join us again next week. And once again, thank you, everybody.